The next speaker is Dr. Shibal, and she'll be talking about the laser remodeling for the first as a first line management for POAG.
Thank you so much for having me here. Thank you, GSI. Thank you, AIOS. It's a privilege to be amongst friends. After Prasanna's rather dynamic use of the trabecular meshwork and destroying it right, left, and center, yes. All right? Okay. I'm going to talk of how we preserve the trabecular meshwork. Remember, the TM is an alive structure. It's a dynamic aqueous pump which shunts the aqueous through. And the trabecular meshwork, therefore, is something to be preserved as often as we can. Are we throwing out the baby with the bath water every time we are stripping the trabecular meshwork 360 degrees? Is a question we need to ask ourselves every time we call MIGS minimally invasive, because when you're stripping the entire trabecular meshwork, it is conjunctival sparing, it is not minimally invasive. I'm going to talk of the trabecular meshwork today and how it can be remodeled. Those of us who have enough gray in our hair have been extremely skeptical about remodeling of the trabecular meshwork because we were exposed to ALT in our initial years of practice. But selective laser trabeculoplasty is entirely different from ALT. So I would like you to look at the image on the left. That's a trabecular meshwork that has been lasered by SLT, and on the right are the craters of argon laser trabeculoplasty. The spot sizes are significantly larger, the pulse duration is significantly less, and the damage that you see to the trabecular meshwork is also significantly less, and which is why SLT can be repeated safely and often enough, which is also why SLT is relatively safer. The results, the 6-year results of the LIGHT trial are with us, and it is absolutely non-controversial on this one that this is very, very different from ALT, and hence at 3 years, almost 75% of patients, and at 6 years, as many as 70% of patients post-SLT were both medication and surgery-free while maintaining their target IOP. But what is dramatic is the relative risk of everything between SLT and medication. I'm going to walk you through this slide. There was significantly less disease progression in the SLT group. While medication patients were at 27%, SLT was at 19.5. There was faster visual field progression. The number of eyes that needed trabeculectomy were more in the SLT group, but significantly less in the medication group. Cataract surgery eyes were similar. The adverse events overall were similar, and ocular adverse events, none of them severe, were also comparative between the two groups. So what we know for now is that SLT provides a stable, drop-free IOP control to almost 70% of POAG patients for up to 6 years. There is a reduced need for surgery. It's a lower cost procedure. There's a lower rate of progression and comparable health-related quality of life results as medication. An IOP drop of 5 millimeters from pre-treatment IOP increase of 5 millimeters, an IOP spike was noted in 1% of patients with SLT, and only one eye of those require treatment. And it has also proven itself to be a reasonable alternative in angle closure with appropriate case selection. Also, the initial cost of SLT, of course, is formidable for most of us who are not in group practices, but the long-term cost effectiveness in terms of health economics of glaucoma is also proven to be inequitable. So then what it is exactly that we have to look for in the future? Direct SLT, and the results of the GLORIOUS trials are awaited, but the preliminary data is very promising. Here, the SLT is delivered directly to the trabecular meshwork through perilimbal area. 120 shots, 3 nanoseconds, 400 micron spot size delivered at the limbus over 2 seconds, obviates the need for locating the trabecular meshwork, and there is no contact lens required, so making it much more acceptable to the patient as well. Micropulse laser trabeculoplasty, of course, uses short, low-energy pulses of laser light, preserving tissue and minimizing the risk of scarring while still improving the aqueous outflow. There is no significant difference in IOP reduction, failure, or number of drops between SLT and MLT at 1 year in controlled studies, and there is a significantly lower rate of IOP spikes with MLT as well. This is the newest kid on the block, and while it hasn't reached any of us, it is now documented as evidence. Femtosecond laser image-guided high-precision trabeculotomy, FLIGHT, is perhaps the true MIGS that we will all be looking forward to. At 24 months, there was a mean reduction of IOP by 35%. In almost 82% patients, they reported a 20% reduction in IOP. It was a small group, 18 eyes of 12 patients, and both Vialase laser and the AIOS system have both proven to be effective. If you would look at the small blue box, that's the laser treatment area that's centered over the trabecular meshwork. Those of us who know how to do LASIK will find it easier than anything else. You just make sure that the aligned red dots are overlapping, and that's when you aim the laser and shoot. It is known to be effective over 24 months. On gonioscopy, you can still see the opening that has been made, as the well-defined channels are also clearly visible on ASOCT for after 2 years with no evidence of closure. So what do we know about POAG TMs? SLT can be the first line in treatment naive eyes and as an adjunct. Emerging protocols using lower energy settings show comparable efficacy with fewer side effects. Of course, the caveat is that we need to continually monitor the glaucoma status with periodic follow-ups, and the course trial results are awaited so we know more about retreatment. The barriers to adoption remain the initial setup costs. This is more true for individual practitioners versus group practice, and health economics of glaucoma versus clinician investment. SLT will pay for itself in the long run if you have a huge patient base, and when you look at something which is minimally invasive and more acceptable to the patient, then this is again something that you are going to have to discuss with your patient, because the acceptability of lasers, thanks to LASIK, is very, very high. But the other part of this is that you have to remember that there is an initial resistance in patients when they look at getting a procedure done on the eye. Apart from this, there is also the impression that a laser is a one-time shop, and then once you've had your laser, you're fine, and that's something that you need to discuss with your patient, that an SLT is not the end-all of glaucoma management. You will need to remain in very, very close follow-up following your SLT as well. What then constitutes a low-resource setting? And again, I'm going to refer to Prasanna's presentation when he spoke of low-resource MIGS. What constitutes low-resource settings? Is it drugs and follow-up that is the low resource you're talking of? Or is it the establishment cost that is the low-resource setting for you? And that is where you need to make your decisions when you're looking at glaucoma practice. Barriers to adoption. The biggest one, the selling point was SLT, is that eye drops aren't winning any popularity contests either, and is true for anything in glaucoma. You need to customize to what your patients want, what you think is the best for the patient, and what you think you can do best for your patient. As far as the future is concerned, custom laser parameters, AI algorithms that use imaging data to optimize laser energy and spot placement, improving IOP reduction. Predictive modeling, you could look at patients who are responding to Ripasidil. AI can predict which patients will respond best to laser therapy based on angle anatomy and IOP history. Advantages, of course, are precision, consistency, and better outcomes. As is true for laser iridotomies, now we don't think of an Nd:YAG laser for iridotomy as a big investment. Perhaps SLT is to go that way at some point in time. Lasers reduce long-term costs by 30% compared to drops. Better patient outcomes, better acceptance, adherence, fewer side effects, and improved quality of life. Lasers are, of course, paving the way for personalized precision medicine in glaucoma. The setup cost needs to be lower for increased adoption, and that's the low resource setting conversation that we all need to have. Thank you so much for having me here. As is true for almost everything in glaucoma, it's science and compassion that leads to clinical outcomes, and SLT